My name is Jessica Probst-Westlick, and I am a PGY1 pharmacy practice resident at St. John Hospital and Medical Center. The study design that I will be discussing today is the non-inferiority design. My objectives for this video are to be able to describe the differences between superiority, equivalency, and non-inferiority trials, to discuss the potential utility and limitations of using a non-inferiority design, to explain how a non-inferiority trial is designed, and to recognize the common pitfalls of analyzing a non-inferiority study. Randomized controlled trials can generally be stratified into three unique study designs: superiority, equivalency, and non-inferiority. It is important to be able to distinguish between each of these designs in order to perform a proper literature analysis. The first of the three, the superiority design, aims to answer the question, is it better? Typically, to answer this question, the new therapy is compared with either a placebo or an active comparator. The investigator pre-specifies an outcome, and if the value of the outcome in the new treatment group turns out to be better, the null hypothesis is rejected, and the new treatment is deemed superior. Equivalency studies differ in that they do not aim to prove that a treatment is better, but rather that it is similar enough to another treatment. Since it is impossible to prove exact equivalence, a margin for comparison is chosen. This margin is compared with the confidence interval around the difference between the two groups. If the confidence interval falls within the margin, the two treatments are deemed equivalent. This design is commonly used to compare a generic medication to the parent drug that it is mimicking. Lastly, the non-inferiority design sets out to answer the question, is it unacceptably worse? This may sound similar to equivalency, but the conclusions reached by each of these designs are very different. Non-inferiority studies do not prove that two treatments are the same, but rather that at the very least, the new treatment is not much worse than the comparator. So why would we ever want to test a new therapy that was potentially slightly worse than existing therapies? One possible explanation is that in some situations, a superiority study may be unethical to perform. For example, if an effective treatment is available that helps prevent morbidity and mortality from a disease, it is unethical to withhold this treatment from some study participants by giving them a placebo. Another situation that a non-inferiority design might be appropriate is when the new treatment is not expected to be more efficacious than the existing treatments, but may have another benefit to offer. For example, this could mean it has a better safety profile, a more favorable dosing regimen, or it may allow for a better quality of life. Like any other study design, there are some limitations to using the non-inferiority design. For example, even if the study drug turns out to have a more favorable outcome than the comparator, this cannot be used to claim superiority because the study is not designed to evaluate superiority. Similarly, just because a test drug is shown to be non-inferior to a treatment that has been proven effective, this cannot be used to independently claim efficacy. Efficacy must be demonstrated with a superiority study in which the drug is compared to placebo. Another limitation of the non-inferiority design is a phenomenon called biocreep. This is the idea that when two drugs are compared in a non-inferiority study, one may be just slightly worse and yet be deemed to be non-inferior to the other treatment. This slightly worse drug may then be compared to another treatment that is again slightly worse, and this drug could too be deemed non-inferior. If this process continues to repeat itself, there is concern that we may end up with treatments that are no longer better than placebo. Lastly, non-inferiority studies require larger sample sizes, a requirement that is not always easy or practical to fulfill. A few important components of the non-inferiority design to become familiar with are the hypotheses, the proper population for analysis, the selection of the active comparator group, and the selection of the non-inferiority or NI margin. The hypotheses for a non-inferiority study take on a slightly different format than other studies that you are familiar with. Typically, the null hypothesis will state that there is no difference between two interventions, and the alternative hypothesis will state that there is a difference. For non-inferiority studies, the null hypothesis instead states that the intervention is significantly different than the comparator by at least the ni margin, therefore stating that the intervention is not non-inferior. The alternative hypothesis states that the intervention and comparator are not significantly different, implying that the intervention is non-inferior. Though the format of the hypotheses for a non-inferiority study is different, the goal of the study is still the same: to reject the null hypothesis. If the null is rejected, then non-inferiority is met. While the intention to treat population is typically used in the primary analysis of superiority studies, using this population may make it more easy to show non-inferiority due to improper randomization. This would not be an issue during per-protocol analysis, since only those who adhere to the treatment would be analyzed. Therefore, it is the FDA recommendation that non-inferiority should be demonstrated using both of these populations. For the conclusions of a non-inferiority study to be valid, it is imperative that an appropriate active comparator is selected. The active comparator is the treatment that the new intervention is being compared to. The comparator should be well established and a standard of care agent that has already proven superiority versus placebo. The studies proving the efficacy of the active comparator should be designed similarly to the non-inferiority study, especially in that they should be looking at a similar population and a similar outcome measure. These placebo trials should also have an adequate sample size in order to establish efficacy, and should be well designed. All of these components are important because the conclusions of a non-inferiority study cannot be meaningful if the active comparator has not already been proven effective. The non-inferiority margin is the largest clinical difference between the intervention and active comparator that is deemed to be acceptable. The difference between the groups must be less than this margin in order for the intervention to be considered non-inferior. The ni margin should be predetermined in order to prevent bias and developed using both statistical techniques and clinical reasoning. Statistically, the starting point for choosing the ni margin is with the placebo studies for the active comparator. In these studies, the active comparator was shown to have a certain amount of effect. The placebo group may have shown a small effect as well, due to various potential confounders or biases. When the effect in the placebo group is subtracted from the effect of the treatment group, this gives the absolute treatment effect. Knowing the effect of the active comparator can serve as a starting point for the effect that you will be looking to see in a non-inferiority study. To demonstrate the process of defining the ni margin, consider an active comparator blood pressure medication that was shown to have a treatment effect of 13 millimeters of mercury systolic blood pressure reduction during efficacy trials. The corresponding placebo group in the efficacy study had a treatment effect of 5 millimeters of mercury reduction. When placebo effect is subtracted from the treatment effect, this leaves us with an 8 millimeter of mercury reduction with a confidence interval of 3 millimeters of mercury to 11 millimeters of mercury. From here, we want to select the lower end of the confidence interval, 3 millimeters of mercury, representing the minimum effect of the treatment. While 3 millimeters of mercury would be considered statistically significant, this is where clinical reasoning must come into effect. Some might argue that a 3 millimeter of mercury reduction in blood pressure is not clinically significant. If this is the case, the margin can be made more stringent. For example, the researchers may decide that the difference needs to be a 5 millimeter of mercury reduction in order for it to be clinically relevant. The non-inferiority margin, shown here as the red line, is extremely important for interpreting the results of a non-inferiority study. If the confidence interval for the treatment group crosses the non-inferiority margin, non-inferiority is not shown. If the confidence interval does not cross this line, the treatment is similar enough to the active comparator, and the two are considered to be non-inferior. The green line shown demonstrates the point at which the treatment group has the same effect as the active comparator. The treatment group may fall on either side of this line, either having a slightly better or worse outcome than the active comparator. But remember that this information cannot be used to conclude superiority. When analyzing a non-inferiority study, don't forget to ask yourself the following questions. Is the efficacy of the reference drug well established? In addition, Make sure that the efficacy studies for the active comparator are similar in population and outcomes to the non-inferiority study. Lastly, it is important that the authors of the study predetermine the NI margin and choose a margin that is both statistically and clinically reasonable. Not predetermining the NI margin introduces bias and may signal that the study is a superiority study that failed and was converted to a non-inferiority design. In conclusion, non-inferiority studies are designed to show that an intervention is not unacceptably worse than a well-established comparator. They are particularly useful when a new treatment may not be more effective than the standard of therapy, but may offer additional benefits in the way of safety or convenience.